Diversa. I'm an internal medicine doctor. I came here in '94, about the time that gentleman came here. When did you come here? 95. I was a medical student. So I did internal medicine here, was a hospitalist here, and now my title is Physician Advisor Revenue Integrity. And I have a practical lecture for you today. I'm going to talk about our star rating, what is a star rating, a little bit about that, and then how physicians can, and providers, nurse practitioners, PA, residents, fellows, can impact our star rating, and why I think our star rating doesn't accurately reflect what we do. So I like to roam around. That's not because I'm a nervous or an anxious person, but I like to keep people awake, you know, and so when I walk around, it's just because I have a tendency, I'm an old man, I fall asleep in lectures, so I'm trying to keep you guys awake. So do you want more stars, documentation, and quality metrics? I've got all these little silly numbers behind my name with certifications that I worked very hard to get. But basically it says I'm an expert in documentation, an expert in coding, and I think I've worked long enough in a hospital to understand how clinicians use the medical record. We use the medical record. We're taught to use the medical record to communicate to other clinicians and to keep the lawyers off our back, when actually there are many, many people that use the medical records, coders, quality metrics, in ways that many times clinicians don't think about. That this discharge summary, I was taught, make the discharge summary so that the person that's going to see the patient and follow up knows what to do next, when really there's so much more that the discharge summary needs to include. No relevant financial relationships to disclose other than I work for Erlanger, so y'all know what that means about money. I hope to have you understand the difference between inpatient and outpatient status, because that does impact our quality metrics in ways that was surprising to me when I realized that. Know what a 2-midnight rule is, why it's important, and why you want to respond to queries that coders or clinical documentation improvement staff will give you, and how to do that optimally. I coerce some of them to come in. I want my CDI nurses to stand up, please. I want them to know who you are. These are registered nurses who are expert in their field. So we have a young lady that worked in post-op open heart for a long time, and now she reviews those records to make sure that the documentation optimally reflects how sick the patient is. And when it doesn't, she uses clinical indicators to prompt the physician as to why you might want to write it a little bit differently so that it does reflect how sick the patient is, because she kind of gets what's going on. So what is star rating? This is not a star rating lecture, but I want you to understand what does it mean by that? Why did CMS, which is also Medicare, which is also the government, they developed this so that consumers could make more informed decisions. It's kind of like Yelp for hospitals. You know, most people go online, they're going to go to a restaurant, they want to know what people say about this restaurant. It's kind of a way what that is. So it's designed to change over time as we have different metrics that we do for quality that we improve on, and we optimize, we kind of get rid of those and add some new ones on. It's very odd because the star rating of the hospital is based on Medicare patients, and what I use the word straight Medicare, not Medicare Advantage plans. But some of them also have other patients, and some of them even have VA patient data. But it's supposed to reflect the care that all the patients, and for our hospital we have about 30% of our patients have straight Medicare. So 30% of the patients we have in our hospital are being monitored and will reflect how we do universally as a hospital. So if you think about how that's imperfect, that doesn't say what we did for 70% of our other patients, but that's the way it is. That's how they measure it. And why stars? Well, because it's a shorthand. Everybody understands 2 stars is better than 1 star, 3 stars better than, you know, up to 5 stars. So Hospital Compare, anybody heard of Hospital Compare in the room? Anybody heard of Physician Compare? Because that's out there now. So Hospital Compare is a consumer-oriented website that the federal government does where they provide information about hospitals. You can go online to this website and you can say, here's my zip code. It'll tell you what hospitals are in that zip code. And you can choose Memorial and Erlanger and Park Ridge, and your mother has COPD, and you're trying to decide, if she gets sick, where am I going to take her? And you can go to COPD, and it'll tell you things like, what's the mortality rate for COPD patients who go to all 3 hospitals? It's no different from national average, better than national average, worse than national average. And there are many, many metrics on this. I think it's 80 or 100. And really the star rating came about because they first came out with this and they realized it was too much information for maybe some of the consumers. So they condensed it down to a star rating. Also, it's important to know that the data that you see there now for 2017 reflects stuff that happened in 2013, 2014, 2015. So what we're doing now will be reflecting the improvements that we make now. It may be 2, 3, 4 years before we reap the benefits of those in an actual hospital compare or star rating. Like farmers, you got to plant the seed now to get the benefit later. So they take different parts of hospital compare and different weights about that. These are the types of things that are in hospital compare. And they chose 7 major categories and a percentage of each and put it all together and come up with a star rating. And I'm going to talk about 1 or 2 of these that I think that our providers, physicians, nurse practitioners, PAs, residents, fellows can actually impact directly in the way they document the record. I wasn't supposed to get there yet. So this in 2017 was a snapshot of what the national star rating is for all hospitals that got a star rating. If you notice, 19% didn't get one. And that's because they were either too new of a hospital or they were so small they didn't have enough patients to reach a minimum threshold. So 5% of the hospitals in the nation were 1 star, 16% 2 star, 25, as you can see there. Erlanger, the 1 star hospital, Memorial, 4 star hospital, Park Ridge 2 star. And I just chose one out kind of close to our region that's kind of typically respected, 2 star hospital. And just as notable, if you look at the data, most of the 5 star hospitals that are in the nation are typically small community hospitals. They seem to have an easier time getting a 5 star rating. I'm going to give an opinion. A lot of this is my opinion. My opinion is when you have more ill patients, there's a bigger documentation burden to ensure that you show how sick they are in the record in such a manner that the coders can capture that severity of illness. When you have patients that aren't that sick in the first place and later on they don't have mortality, well, you don't get dinged because you didn't write down how sick they were. If we have stroke patients here that have a lot of comorbidities and we forget to or don't understand how important it is to put the fact that they have bipolar disorder on admission, which is used to risk stratify that patient later for mortality, then we kind of get dinged for that when those patients end up dying and it wasn't anticipated or calculated that they would die. Percentage of them. So it's very confusing, very complicated, and what my goal is to try to find a few highlights and give examples about what do I do now, because sometimes when I talk about this to doctors, like, okay, so that's a whole lot of actuarial stuff, lots of people there, what can I do today when I go see patients tomorrow in my clinic that will make a difference to this? And I'm hoping to give you something to take home that you can do with that. So let's just talk about mortality, 30-day death rates. Erlanger Medical Center, you can go on hospital compare. COPD, worse than national average. Stroke, worse than national average. Memorial Hospital, stroke, no different than national average. So if you were a normal consumer who doesn't know anything, you don't have a friend who's a doctor to say, where do I want to go for stroke? An internationally known stroke center, Erlanger Medical Center, it's got worse than national average mortality rates for stroke. So as people say, well, of course, we have sicker patients. Well, the point I'm trying to make is if we accurately were to reflect how ill our patients were in the medical record in such a way that the coders can capture it, I always have that caveat, then we wouldn't be this way. I believe it's because we don't understand the rubric, how we're measured on it. I know some people like to come up with mortality scores. Yale came up with some ways to kind of predict what someone's mortality will be. And Medicare asked them to do this. And so that for acute MI and heart failure, you actually can go to these websites and you can plug in data about the patient, the age, sometimes the last BUN, things like this, different things that they found that were impactful for predicting a mortality. And in your individual patient, you can come up with a mortality score, what the predicted mortality will be for a specific individual patient. So the death rates, based on who we have admitted to the hospital with a stroke, I'll use that one, is how many of these people will be estimated to die within 30 days of that admission. And this is the part that drives me crazy. But the government, I don't want to try to justify what they did, but they said the death is for any reason because they can't decide. So if you came in with a stroke on January the 1st, and I don't want to be disrespectful by saying it this way, but just to make a point, and on January the 25th you're hit by a train and you die, that counts against us. That's a death within 30 days. I think what Medicare says and the actuaries say across the nation, that type of thing probably should happen equally amongst all hospitals. So it still should be kind of reflective of what happens as far as the type of care. It's a very indirect, imperfect way of determining the medical care that the patient received during that hospitalization. And generally speaking, if someone has a death rate, 30-day death rate that's higher than national average, that might be reflective of what's going on in that hospital compared to a hospital that has a lower than national average death rate of 30 days. If you can understand. It's a very imperfect metric, but that's not explained to the patients. It just says worse than national average or same as national average. Many times what I get is, well, if they die for any reason, I can't control that. I can't even control what happens after they leave the hospital if I'm an inpatient doctor. Those types of paralysis that I think that the physicians and providers have. And then this is kind of a complicated way is which ones are included. There's one point I want to make about this is, so it's Medicare beneficiaries 65 or older. I call it, original Medicare, meaning not a Medicare Advantage plan, and they've had it for a full 12 months prior to that admission. And it doesn't include people who leave against medical advice, which kind of makes sense. It's rare that I can say things make sense when I'm talking about these complex government rules, but that does make sense. You don't have to know any of that, but just to let you know, but there again, 30% of our patients are Medicare patients. Not all of them are 65 or older. And not all of them have had Medicare for a full 12 months before they get admitted. So it's a very small subset of our patients in strokes that will reflect what our star rating is in strokes. So you understand what I'm saying? Just to let you know why it's important that one or two charts, the point I'm making is, could make a difference in our hospital compare rating that's not accurately coded or appropriately revealing how sick the patient is. One or two records could make a difference in our star rating and our hospital compare, since it's such a small number in the denominator relatively. And then the other way I want to talk about this is the other point is claims data. So this comes from claims data, meaning it does not come directly from the medical record. So if a physician reads in the medical record how sick a patient is, and it's obvious how sick the patient is when I read that medical record, if it's not written in such a way that those diagnoses can be recognized and captured by the professionals called coders, and then put in an electronic form, put on a UB04 claim, it won't be recognized by CMS. I hope I said that right. So it would be obvious to you how sick the patient is in the record, but it has to be obvious to the coder via diagnoses. I have written, people write moribund, very high risk of death. We get that. We know they're not going to make it. That's not codable. There's not a code for that. So that won't be reflected in how sick the patient is on that claims data. You have to put why you think they're moribund, encephalopathy, acute respiratory failure, those types of things that make you draw that conclusion. So that seems like an overwhelming request. Well, how do you decide that I know? Well, we have clinical documentation improvement nurses whose job is to review the record concurrently. An imperfect process because they don't have time to review all of them, but I don't want to get into that. but their job is to review them, so they look for things in the record. Clinical, they're not physicians, but they are trained, and there's a whole profession regarding clinical indicators in the chart, and are there diagnoses to reflect those clinical indicators, and then ask the doctor about that, or the provider, or the resident, or the PA, so that we can make sure that they're, and that's actually a CMS rule. CMS says if there are clinical indicators in the record that are not explained with a diagnosis, the hospital is required to ask the provider. So if you put in there, infiltrate, white count 20, they're all on IV Levaquin, and there's nothing in that record that explains why you're doing that, the hospital is required by CMS rules to ask, what are you treating here? So it's not really phishing, it's actually a CMS requirement. The opposite is true, just by the way, if you write down pneumonia, but there's nothing in the record to support that clinical disease, there's no white count elevation, there's no infiltrate, there's no antibiotics, we're also required to query about that. We notice there's a diagnosis of pneumonia, and many times it's very appropriate, it's just not written in such a way that it's obvious to all the other parties besides physicians who read that record. So that's a concurrent review, hopefully. And then when it gets to the coders, these are off-site professionals that look at the record, electronic record, and if they see something, they may also send a query to you. So just for a moment, I gave a lecture 2 or 3 times at a national meeting called Query Weary Docs. I was losing my mind when this all started with these CDI queries, and they were asking me all these questions that drove me crazy about, why are you asking me these questions? You know, now I want to make sure, I finally got it. I am a clinical doctor. The reason they're doing it, and actually it's to help you. You haven't shown how sick the patient is. My estimated mortality in my cancer patient is going to be made based on the diagnoses, and he has a hint that I have not written it in such a way that that estimation will be accurate. So they're actually doing me a favor by saying, hey, you might want to look at this. When you've got competing responsibilities and a lot of work to do, it may not feel like someone's doing you a favor by giving you another task to do an epic, but I think they are. So the 30-day rates, they had actuaries look at this, certain diagnoses. They decided if a person was admitted with a stroke and they were 90 years old, so a very simple description, they're more likely to die than someone who's admitted with a stroke who's 60. We all get that. Some things are not intuitive. If a patient's admitted with a stroke and they have bipolar disorder, they're more likely to die than someone who doesn't have bipolar disorder. I can't explain it as actuaries did all this. A long list of diagnoses, some that would risk adjust up, meaning be more reflective of a higher risk of death, and actually some diagnoses risk adjust down, that you're less likely to die if you have certain diagnoses. There are very few of them, to be honest with you, that the comorbidities that really have an impact on adjusting that risk up that we miss. We rarely don't put acute renal failure, cancer diagnoses in addition to the stroke. But there are some that we, in the CDI world, kind of see left out sometimes. These are some that I kind of see. And, I've been a hospitalist. The patient's got a brain hemorrhage, or they're admitted with a stroke. They came from some other place by helicopter. There's no family available. You have a medication list, and you're worried about, do we need to intubate them, keep their airway open, control their blood pressure, get them in the ICU? And it's, it kind of feels odd to me. I get it as a hospitalist. I'd be asking, does mama have dementia? It doesn't seem like it's the right time, or there's a time and a place for these types of things. But you may notice the next day, if you're the team that follows up, helping your partner out. Because we fortunately do some piecemeal. The fortunate part is you have different professionals have an opportunity to be exposed to the patient's presentation. The unfortunate part is continuity of care can be quite a challenge. That you see a list of medications that include dementia-type medications is perfectly acceptable and should be done that on day 2 or day 3 when it becomes obvious, or more appropriate time to gather that history. It's perfectly okay to say on day 3 in your progress note, diagnoses, dementia, present on admission. And that will capture that metric in such a way that it can be appropriately used to risk stratify the patient. People who come in from COPD, probably most of the time we include this, but we may not, that if they've ever been intubated in the past, because of their COPD, that would be not that they're intubated this time, or that you even think there's a risk of them being intubated. It's important to include that because that risk adjusts that patient. We do know that asthmatics that have ever been intubated are typically higher risk patients that don't, and many times, and I've thought about my own practice. I remember I always would include that, but I may or may not include that 10 years ago this patient with emphysema had been intubated for their emphysema. Chronic liver disease, sometimes, this is just my opinion of things that I sometimes see left out in an acute setting with higher priority things that the provider needs to deal with. You know, trauma patients that come in, they may or may not list the hepatitis C or the other chronic liver diseases. Atelectasis in patients with COPD, I see it all the time on the chest x-ray reports, but it can't be captured by the coders unless it's written as a diagnosis, atelectasis. And that seems so, you know, counterintuitive to a physician, because according to this risk stratification methodology, it doesn't matter why they have atelectasis, but do they or do they not have atelectasis? And sometimes providers and physicians, we won't write down atelectasis unless we think it's like a significant problem that we're going to address and do something about. It's just going to be the same: turn the patient, deep breathe, cough, the I cough order set. But actually, that diagnosis can't be captured in a way that can be utilized to risk adjust the patient for all these other metrics going forward unless it's written as a diagnosis. Depression counts, bipolar disorder counts. And there's a real art to how do you ask those types of questions when there is another reason for the patient to be admitted to the hospital. So I'm very in tune to the fact that the timing is everything, and how you ask that question and when you address that question with the patient in such a way that, and so that's a real nuanced thing. It many times can, when you're a hospitalist or you're just meeting a patient for the first time on the inpatient, you may or may not have the opportunity to build rapport in the first 5 minutes to, you know, they're there for some other reason that has nothing to do with an emotional, that's such a touchy subject in society today that many people feel that there are other consequences or other intentions when you're asking about a history of depression or anxiety or bipolar disorder, other than you're just trying to get their medical record. So I'm aware that that can be a sensitive subject and have consequences to the patient's perception of the physician-patient relationship, the timing of when to do that. That's why I always remind it is perfectly acceptable, even on the day of discharge of a 12-day stay, if you say depression present on admission, that's perfectly acceptable as you get to know the patient better and things become more obvious. So only patients. So when I was taught years ago, I didn't understand the difference about status, inpatient, outpatient. When someone told me there was an outpatient, I thought they meant they weren't in the hospital, they were out there somewhere doing something else. But outpatient means they're in the hospital bed, outpatient status. Inpatient status means they're in the hospital bed. So two patients can be admitted with the same diagnoses, same orders, same everything. One can be an inpatient status, one can be an outpatient status. Same nursing care, there's no difference. To the doctor, you don't see anything differently. It's really a payment issue, to be honest with you. There's certain rules and regulations about who is an inpatient, who is an outpatient. They can be quite complicated depending on who the payer is, who the payer happens to be. We have utilization review nurses who are required to review all patients admitted to a bed in the hospital within 1 business day, and if the documentation supports the status that the physician has written, inpatient or outpatient, it's kind of blind to the doc or the nurse practitioner that wrote that initial order, or the PA or resident. And if it doesn't, then they will interact with the utilization review physician, which is Dr. Adam Fall, Dr. Lisa Dias, or they can't resolve it, then they might talk to you as to what the status of the patient, what the documentation supports. So I emphasize it's very complicated, and I do think that doctors need to be educated more about this, but we have in-house experts that help guide you through that. You don't have to know all those rules. The point being is when a utilization review nurse contacts you regarding the status of a patient, just try to be mindful that it's intended in a good way to be compliant with CMS guidelines. So the point is, I hope I remember how you said to do this. Status does not impact location of care or amount of care. If a person comes in with a stroke and they're an inpatient and they die, that counts against us on the quality metric. If a patient is admitted to the hospital as an outpatient and they die, that doesn't count against us as a quality metric. I'm going to let that sink in. I did not say we should be admitting people as an outpatient, for the record. But that's a big deal. We have had some instances when a patient really met criteria for outpatient, but the physician, the nurse practitioner, the resident, the ED doc wrote them as an inpatient. And if we don't fix that prior to them leaving and they have a bad outcome, when they didn't meet the criteria for an inpatient, we just shot ourselves in the foot. Do you understand what I'm saying with that? So we want to get it right. We don't want to make them inpatient or outpatient because of what our concerns are on the impact of the quality metric at all. But we want to make sure it's accurate because there are unintended consequences to it not being accurate. But the opposite may be true. We have patients who do quite well, that have good outcomes, that will help us in our hospital compare metrics because everything went well with them. But if they're an outpatient and they should have been an inpatient, we don't get the benefit of that good outcome, if you follow what I'm saying. So it's just important that the status is accurate. So Medicare came up with a rule. It's called the 2 midnight rule. And Medicare realized it's very complicated, and so they tried to simplify it for the doctors. This is about several years ago. And they said, basically, at the time you're going to, I used to say write the order, but input the order. At the time you're going to, whatever information is available to you at that moment, and you're going to write the order, admit to, if you feel like, based on the needs of the patient, the coexisting conditions, the signs and symptoms of the presentation, the facilities and testing available and resources available to the patient as an inpatient, those available to the patient as an outpatient, do you think they're going to be in the hospital 2 midnights or more or less than that? If you feel like it's going to be 2 midnights or more, then you should write admit to inpatient. If you think it's in your best estimation, and they realize it's an estimation, a guess, crystal ball, less than 2 midnights, you write as admit to outpatient. That's basically the 2 midnight rule. We do have a really good lecture for that Dr. Adam Falls come up with regarding, if anybody would like to have that, we'd love to give that lecture to anybody's, department meetings with examples of this is a case that's an inpatient, this is a case that's an outpatient, this is how it's documented. But basically, if you think they're going to be 2 midnights, you write admit to inpatient. If you think it's going to be less than 2 midnights, you write to outpatient. Now, on the second day, you've written admit to outpatient, and you're not going to send them home, then you morph the order to admit to inpatient, because that will be the 2 midnights. You follow what I'm saying? Or if you're called to the emergency room at 6 a.m. and they got to the emergency room at 8 p.m. the night before, they've already surpassed the first midnight, so you're not going to send them home today. That'll be the 2 midnights, admit to inpatient. And you're not considered non-compliant with CMS if you predicted 2 midnights and they don't stay 2 midnights. I don't want you to feel like there's that burden of proof that you have to show. It's just based on what's available to you at that time. The stark example I use is, it's happened to me twice in my career. Somebody comes in, found down, intubated, no history, no family, no nothing. They're not breathing on their own. And I admit them to the ICU, do the big workup, drug screen's negative, and 4 hours later they wake up, pull their ET tube out, and sneak out the back door of the MICU. I mean, that's happened twice. You ever seen that, Gail? They were just drunk, But at that time, we didn't know that. At what was available to me, the information available to me, they were quite ill, on a ventilator, and we had to support them. That would be a patient I would say admit to inpatient. But in the end, that's not how it. So that's just a stark example of it's not required that you get it right, but it would be reasonable at that time that I wrote admit to inpatient that that's what the typical person would think. Yes, sir?
In the ICU, it's so commonplace. We get the DKs, the gap is going to close in 6 hours.
Yeah.
But they're in the ICU. And it's so difficult to say, I don't want to admit this patient because they don't meet the 2 midnight rule. I want them in the observation category.
Mm-hmm.
So can that be facilitated in some way? Because it seems like right now we're forced to admit to inpatient and then contact case management and reverse it to.
I'm glad
Might be
you
wrong.
I'm glad you said it, because when you do the admit order, whomever does the initial admit order, it's an option to say admit to outpatient. You still will get a bed in the ICU. You can say admit to outpatient, bed request ICU. So,
It's probably happening from the ED, and then when
Right.
they want to downgrade
Right.
it, it's not being.
yes. So I do believe that we have a habit. My personal perception is we have a habit that the doctors don't think about it. They may have actually been coached to not think about it. Just make them an inpatient and we'll sort it out on the back end. That's really my personal opinion. I want to do some things, some education, and maybe change that where there's an actual thoughtful process on the front end by whomever writes that order, the ED doctor, wherever I'm going to direct the education, who are the night float team or whomever, that you really think about which one these are so we get it right from the beginning so there's not a bunch of cleanup on the back end. Thank you for the comment.
You go in a reverse order, like you made somebody an inpatient, you come on the next day and say, they've been notified now, you can come back.
Yes, thank you. The question is, can you go in the reverse order? I think, as you were saying, they were admitted as an inpatient, but you really believe that, and it was probably your partner that admitted him as an inpatient or the ED doc in reality. You say, this is not an inpatient. I believe they meet criteria for outpatient. Yes, you may. If they are a Medicare patient, that requires the input of the utilization review physician. So it'd be a physician, you and Dr. Fall, you and Dr. Dias would talk about it, you'd agree with it, and there's a condition code 44 that the UR physician is required to do, not you. But if it's anything other than straight Medicare, you can just write change to outpatient status, change to observation status. And if that's the accurate status for the patient, that's what I want you to do. But I don't think doctors feel empowered to do that, or they get some pushback. So just as a moment, I'll talk about what do you do if you want to do that, but the UR nurse says, but they meet criteria for inpatient. What she or he is saying is based on the recognized, there are third-party Milliman care guidelines, different things that are used. Despite your opinion, based on this, they actually do meet criteria for inpatient. It's still the physician, as rare as it is to be able to say this, the doctor still gets to make the call. But I do say that you should take into consideration, what a third party would say if they looked at this record. So when they say, well, they meet criteria for inpatient, then, that's why when you want to change it on a Medicare patient, they require that you speak, Medicare requires that you speak with the utilization review physician because they're the experts in utilization review, because Medicare wants it right. And they feel like if a physician decides someone should be outpatient, that they deserve the expertise of a UR expert to make sure that is an accurate decision. We don't do that much here. We should be doing it more, to be honest with you, just based on the number of admissions that we have and the number of times that somebody's admitted to an inpatient. So I want to encourage you to reach out to the Dr. Fall, Dr. Dias, or the utilization review nurse to facilitate that. The point being is we've had 1 or 2 cases a year in the past that were like MIs or labeled as MIs, admitted as an inpatient that really didn't meet inpatient criteria, and they're the ones that caused us to get that 1 star, like one patient. It can come down to that. So that's why it's important to get it right. And you can't retrospectively go back and fix it. So even if in the review of the record you say this should have been an outpatient all along, CMS will not allow that. Commercial insurance will allow it. Medicare Advantage plans will allow it, but Medicare will not allow you to go back and change that order to outpatient after the patient has left the building. This is important. And so our metric is based on Medicare patients. So Medicare won't let you change that to an outpatient after they've left the building. So that's why it's got to be accurate before the patient leaves the building. So there have been times, Dr. Wooten, physician and advisor for quality, she looks at these cases of people who die in the hospital. Dr. Wooten, many times, Ms. Kyra Brown, please stand up. She reviews all cases of patients who die in the hospital because they, by definition, meet that 30-day rule because they died in the hospital. And so she looks at all those cases as a coder with many years of experience to make sure that all those diagnoses that the patient may have had are actually accurately documented in such a way that the coder could. And then she may need help with, she consults with Dr. Wooten about this, and then sometimes Dr. Wooten will look at the case and say, this really didn't even meet inpatient criteria it's going to count against us when really it probably shouldn't have. And so that's why we realize we need to give some education about status. And that's also why you might get a query on a patient who passed away. Many times I've had doctors say, why does this matter? They're gone. Because of these quality metrics, hospital compare and star ratings. You want to make sure that the patient, like, yeah, they were sick, they died. I don't want to be, minimizing this. But some of the physicians, well, how much more sick do you want them to be? They died. Well, you need to show how sick they were so that we get the credit, so-called credit for how the severity of illness and risk of mortality. So this is an important one. If the patient has already surpassed 1 midnight as an outpatient or sitting in the ED, and you are then deciding about admitting them, then that's an admit to inpatient. And many times in the emergency room, in all honesty, if it's right after midnight or 8 o'clock in the morning, they've been in the ED all night long, or they were in Dayton Ray Medical Center before midnight, or they were in Bradley before midnight. That counts also. It doesn't have to be our hospital. They've already surpassed 1 midnight. You're not sending them home today. That's an admit to inpatient. That's pretty easy. Or you come in on Tuesday. They're admitted as an outpatient on Monday. You're not going to send them home on Tuesday. That's admit to inpatient because that's going to be your 2 midnights. I think the most grief I get from doctors when they say, well, this could go either way. It depends on how long it takes me to get an MRI, how long it takes to get the echo. I think it could be done in less than 2 midnights, but there's so many variables I can't make this call. That can be a little bit tougher on the physicians to make the call. But when they've already been here or somewhere for the first midnight, then admit them. Or someone had some kind of elective surgery the day before and they're vomiting or they can't urinate, they're not going to go home today. That's an admit to inpatient. 2 midnights. So CMS says, they always think that, I think that sometimes they say things in such a way that they think that, well, people will drag their feet and keep people here for 2 midnights just to meet that 2 midnight criteria. So they'll say, well, they have to meet medically necessary treatment during that time here. It's not hard. To be frank with you, and I'm making a generalization here, we have very ill patients here. There's always a lot of pressure for the teams taking care of the patient, be you a teaching team or a hospitalist team, to ensure that the patients only stay as long as they have to stay. I really do not believe we keep anyone in the hospital bed longer than they need to stay. We could always maybe do better with that, but no one sits around here at the spa at Erlanger on an inpatient. That's just my opinion. So this is how you feel sometimes when you've worked so hard to keep the patient alive, understand the diagnoses, make that diagnosis, do the treatment, treat the DKA, close that gap, and then you got these little people coming asking all these questions about inpatient, outpatient, CDI, do they really have hyponatremia? Sometimes that's how it feels to the providers. It's like, I'm doing my job, I'm doing the medical care of the patient, they're doing well, why are you asking about these questions? So why do we have CDI queries? So they don't realize, many providers, doctors, residents, fellows, I was one of these, that the words that they utilize in the medical record do not sometimes, and typically as they get feedback from CDI nurses, this improves, aren't sufficiently descriptive in such a way that the true nature of the patient's illness can be accurately understood through the lens of a coder's glasses. And that's the important part, the coder, which is, if you have any family members that are looking for a job, we need more coders in the world. It's a good job. It's a profession. You have to take certification tests. We typically document for the benefit of other physicians, other providers. We don't think about a coder looking at the record, but I want to tell you to make sure you take care of the patient and communicate with other providers. Epic has, I believe, made that even more of a challenge to even communicate to other providers. I don't want to, be negative, but I think a little bit of data overload there. But it also has to be understood by the coder. And there are some ways that we see things in the record that are ambiguous or contradictory, and patients obviously quite ill, and I don't think the doctors understand the consequences. I've seen things like, beautiful job of talking about how ill the patient is, the emergency room care, they require inpatient admission, admit to inpatient order, and in the H&P plan, Diagnosis will admit to the hospital for inpatient for 1 to 2 days of observation. Well, you just shot us in the foot when you did that. So by definition, admit to inpatient means 2 midnights or more. And then they'll say 1 to 2 days of observation. And then they even, so, because auditors look at these things, well, it says right here, 1 to 2 days of observation. So this inpatient admission is not valid. You follow what I'm saying? That we don't think about how that can be teased apart by non-physicians. When I read that you put that in, I know what you mean by that, but a coder will take it quite literally and possibly it means something different. I believe that this is due to the fact that there's competing responsibilities of physicians. I believe that physicians that are given the resources to do and nurse practitioners and PAs, residents and fellows, that they want to have the resources, the support systems, they want to do the right thing. Just tell them what they need to do. They desire good outcomes with their patients in such a way that it's obvious to everyone they have good outcomes. This is one that you know about, Miss Barbara. I always use this example. Several years ago, I kept getting a query about hyponatremia from this young lady right here. She's the reason that I'm a CDI specialist. She would say, "Dear Dr. DeVersa, we noticed the sodium is 108, 109, 110. We noticed you gave normal saline. What is the diagnosis? Hyponatremia, abnormal lab value, unable to determine other." And I'd say, "Why are you asking me this question? By definition, hyponatremia is an abnormal lab value. I don't understand the question. You're irritating me. You know, I got 40 patients to see today, back in the day. Why am I asked this silly question?" You know, it's really a very disrespectful tone that I took, in all honesty. And I think it's because I didn't understand what she was trying to help me with. Because in actuality, we all realize in that bell curve, you can have an abnormal lab value just because not all patients meet that. We have normalcy depending on the bell curve. And there are some people that are in that 2.5% on the either end of a sodium that, yes, for the lab it's abnormal, but it's not indicative of a disease state. Physicians understand that. Sometimes it's just an abnormal lab value. Some people say if you do a Chem 12, a CMP on patients, chances are one of those tests is going to be abnormal just statistically. Or is it actually a reflective of a disease state in the patient? A patient with pneumonia who actually has hyponatremia has a higher risk of mortality than a patient with pneumonia who has an abnormal lab value. You know, pneumonia is one of those different predictive scales that you can use to determine about who needs to be admitted as an inpatient based on their risk, and hyponatremia is one of them. Same thing with elevated creatinine. So it is important to include in the record if they have hyponatremia or not. It's important to know, is this reflective of a disease state? A lot of respiratory patients will have hyponatremia. As providers, we see that, we notice. We may not do anything other than surveillance of it. We may not even treat it with saline or normal saline, but we also know, yeah, we see that with lung cancer patients. They have hyponatremia. But it still needs to be documented as a diagnosis so that it can be captured for the predictive value and the risk stratification of the patient. That's the point I want to make, something as simple as that. So she was doing me a favor, and I appreciate it now. And I appreciate you letting me use you as an example. Thank you, ma'am. So, and it seems when someone is so ill with so many things wrong, it seems kind of like nitpicky to some people that they're being asked about hyponatremia when they had all this septic shock and all these other things going on. But there's a reason that it's important to include that for this predictive stratification of the patients. What's going to happen in the next 30 days. So when someone is discharged with a stroke, they have many diagnoses, but at some point, what is the principal diagnosis? And so that's which bucket they go in. And so it's got to be obvious in the record what the principal diagnosis is. And so unless you write principal diagnoses this in your discharge summary, whichever diagnosis you list first, according to coding rules, they're supposed to use as a principal diagnosis. And many times they'll have somebody with septic shock and they'll auto-populate the problem list, and the first problem will be hyponatremia, pneumonia, shock. And if they don't write principal diagnosis, whichever one they think it is, to the coders, if they were to strictly follow, they're supposed to say hyponatremia. Well, we know that's not the reason, and you might get a query for that. Then make sure you indicate, hopefully in your medical record, but at least in your discharge summary, what the principal diagnosis is. This is probably one of the biggest challenges that we have faced in health information management, clinical documentation improvement, billing, quality metrics as our discharge summaries since the implementation of EPIC. And so I want to spend a little time on this. There are people who do a good job of maintaining the problem list, and during the hospitalization, as a problem is resolved, they'll remove it from the problem list. And then when they do their discharge summary, they'll auto-populate the problem list into their discharge summary, but that problem list won't include resolved problems. So in order for one of those diagnoses to be captured by a coder in such a way that it can be used to risk of mortality, severe illness, it needs to be in the discharge summary. What's my time? They're leaving. So just be mindful of that. It is not we have a policy about copy and paste at Erlanger Medical Center, and it's not a policy that says you cannot copy and paste, but the policy states that if you are going to copy and paste, you have to ensure that what you copy and paste is accurate. I see frequently people have problem lists of something that happened 5 years ago, and their problem has nothing to do with going on this drive, so the coder's crazy, and it has nothing to do with that diagnosis of that hospitalization, but since it's in the discharge summary, they're supposed to code it, which may or may not have anything to do with it, which may actually put us in one of those categories that could hurt us.
Dr. DeVersa. So question, on the one hand, you want us to document as much of the severity of their prior illness as possible, right? But that's not going to be in the problem list, or it is going to be in the problem? Do you see what I'm saying? Then on the discharge summary, you don't want anything on there that doesn't have to do with the current hospitalization?
I think, so the question is, I emphasize how I want their past medical history and past problems to be included in the record, and that should be the problem list or the past medical history. Keep in mind, just because something's on a problem list doesn't mean it's part of the permanent medical record. You have to make that problem list part of your note. Okay. Many people forget that. They don't realize that. So in your H&P, if you auto-populate that problem list into your note, then it's memorialized into the medical record. So just because it's in EPIC in a problem list, it has to be part of a note. And that's why people populate the problem list to the note. And that's all well and good on the H&P about previous problems, what was going on in the past. Well, what you'll see, it'll say acute MI on a previous problem list. And then so when someone, that happened 4 years ago. Well, no one updated that problem list to say history of MI. And so when they auto-populate that into the discharge summary, on the discharge summary it's got acute MI when they were here for pneumonia. That's a very stark example. And so all at once I've got a coder who might actually code this hospitalization as an MI. Because you put, not you personally, acute MI. When really that problem list hasn't been finessed. It's really a history of an acute MI, which is a different thing than acute MI. Previously, someone may have been admitted last year with septic shock on the problem list. Beautiful. No one maintained their problem list and put history of septic shock. So they come in here for total knee arthroplasty. Someone does a discharge summary, auto-populates a problem list. Total knee arthroplasty, number 2, septic shock. You realize what that looks like to a coder, but to someone who's got a lot to do, competing responsibilities, they've got a template that populates the problem list to their discharge summary, but they don't clean that problem list up to make sure it's accurate. Those are stark examples, and that actually has happened. That's what I mean by that. So it's, yeah. Mm-hmm.
Just a quick question. So if the principal problem is the one you admitted somebody with, and say that resolves and there's another bigger problem that happens during the hospital stay, on the discharge, is the principal problem the one you admit them with, or is that the one that...
Thank you for the question. I appreciate that. If the principal problem, what the question is, if the principal problem is one they admitted them with and they haven't, that resolves and another problem comes up, what is? So there's a couple of, the admitting problem may or may not be the principal problem. So, where is that slide? So the condition after study which occasioned the admission to the hospital is what is considered the principal diagnosis, the principal problem. So I may have come in with chest pain. and it was concerned about a heart attack. And we actually found out it was a pulmonary embolus. And there actually may be MI is admitting, well, stroke is admitting diagnosis when come to, I'll do this one. And, you know, they have dysphagia, right-sided paralysis, abnormal MRI, admitting diagnosis stroke. Well, then they realize it's actually a tumor. Well, the principal diagnosis wouldn't be stroke, in that even though that was the admitting diagnosis. But so Medicare says that many times it's not so clear in the beginning. You're doing a workup. You have a suspicion, and you should say what you think's going on. But is at the time that you said the discharging physician's job is a big job. You have to pause and look at everything. Well, after we looked at everything, what really was this? So after study, after testing, after surveillance, what was the reason the patient was admitted to the hospital? So the principal diagnosis sometimes is the admitting diagnosis, but it doesn't have to be. And the principal diagnosis, let's say somebody comes into the hospital to have outpatient appendectomy. Then they puncture their something, and then they get septic shock, and they're admitted to the hospital, and they're in the ICU. Well, their admitting diagnosis was, you know, appendicitis, but that's not really after study. Many people, you know, like an elective outpatient surgery, maybe appendicitis wasn't a good one, that's not the reason they got admitted. It's because septic shock was the reason they got admitted. So that'd be an example. So this is an important thing. And what we see is many of the providers just take the H&P and put it in the discharge summary, when really that, and they may have a principal problem on their problem list, a principal problem, chest pain or shortness of breath, when really they found out it was a pulmonary embolus or it was some other more specific diagnosis, but they never maintained their problem list and changed the principal problem. It's not chest pain or shortness of breath, it's MI or CHF exacerbation. Yes, sir.
So Medicare just on October 1 published some changes to the way they want documentation. On the outpatient side, they're collapsing tools to 2 and 4 level of care, etc. But they've made a statement that they will not ding a physician for not individually in their note including all the problem list.
So,
as long as they say that they've documented and that they've reviewed the problem list.
right.
So will that apply to discharge summaries now, that you don't have to actually say what the discharge, what the multiple
So what kind of diagnoses are required in the discharge
I mean, the principle, yes, but
diagnosis? So the question is, what is the Medicare rules about what needs to be in the discharge? Excuse me. So there's no rule about this must be in the discharge summary. There is a statement in CMS guidelines, which are 3,000 thick. It'll say any diagnosis that was considered important during the hospitalization should be in the discharge summary. So, you know, the government splits words. Should be and must be are two different things. Now, 30% of our cases are Medicare cases. 70% are TennCare commercial. About 35% commercial. Commercial insurances require, if it's going to be important in the diagnosis and you're going to bill for it, it's got to be in the discharge summary. And we're getting dinged for that big time. So it's difficult to say to a physician, well, if they have this insurance, you don't have to necessarily. It's good to. If they have Cigna, you better. You know, so it's just, particularly with Epic, it's easy, hopefully, downside to doing it. So the diagnoses, and some people say, well, how many times do I have to write the diagnosis? Do I need to write every important diagnosis every single day? I would say there's no rule about it, but I would say you need to write it, you know, at some point when you discern that that's the diagnosis that they have, and then for sure, again, populate in the discharge summary, whoever's doing your discharge summaries. Would you like to add something?
That's true. They tell you all one thing for the physician billing side, which doesn't always correlate with the hospital inpatient side.
Yeah, that is an important point you made about the evaluation management billing.
By saying they ding us, what's occurring is they're after discharge and after we've coded these diagnoses, like encephalopathy, acute respiratory failure, they're having their medical experts come behind us and determine that it wasn't clinically as significant enough to the attending physician to put it in the discharge summary. Therefore, it doesn't exist, so therefore they're taking the diagnosis away, which means they're taking reimbursement away from us, they're taking quality data, things that could count for our quality data resources to treat these things, but we're not getting reimbursed for them or getting the effect of the quality data.
So many of the payers have used it as an out. They say, well, if it was important, it'd be in the discharge summary, since it's not in the discharge summary. Now, evaluation and management, physician billing, and hospital documentation, a lot of similarities, but two different things. I want to put a little plug in. Twice a month, I provide free, in the Thompson room, billing education. It's the second Thursday at 7 a.m. That's where I was at 7 this morning. That's why I got here right before 8. It's from 7 to 8. You can bring breakfast, drop in, and I go over the basics of evaluation and management billing. I typically only have 1 or 2 or 3 people, drop in. So today it was an OBGYN, so I can give directed education just about OBGYN. So if you just do only inpatient medicine, I can direct it to that. If you just do outpatient, if you just do critical care. It's also the third Wednesday of every month from noon till 1 p.m. in the Thompson room. You don't have to have an appointment. This month, that Wednesday is the day before Thanksgiving, so it won't be that Wednesday. I'm going to skip it. But every other month, it's the second Tuesday at 7 a.m., the third Wednesday at noon from 12 to 1. No appointment necessary. I don't provide food. I don't have a budget. You're welcome to bring your food if you'd like to attend. So if you have any, if you ever get a query or that you don't really understand, why are they asking me this, feel free to reach out to me. You can find me on Tiger Text. I'm also in the Erlanger email, and I'll direct you to the person to help you understand why are you getting this query. If you ever have a coding question that you'd like to get clarified as to why you're being asked this, please let me know, and I'll get Kyra or Karen to help make that clarification. Thank you for your time. I'll take any questions afterwards. I appreciate it.